Hello, how are you? I'm meeting you on the next session, pharmacology session, and this session is about antifungal agents. Have a look at the table. You know, the fungal infections can be systemic fungal infections or they can be comparatively superficial fungal infections. Systemic fungal infections or superficial fungal infections. When the infection is systemic, we have to use the drugs by the route of administration by which there is going to be systemic delivery of the drug. So we say we are using the drug systemically. So for systemic mycosis, we need to use the drugs systemically. If it's superficial mycosis, if it's superficial fungal infection, you could use the drugs by topical route of administration, that local route of administration, and your infection would get treated. But sometimes the superficial fungal infection is difficult to treat, and in such situations you might have to use the drugs by systemic route although the infection is superficial. So looking at the table, that's the background. There is systemic mycosis here and the superficial mycosis on the other side. For systemic mycosis, we are mentioning the drugs that are always used systemically, and for superficial mycosis, you can use the drugs systemically or you can use the drugs by local routes of administration. Coming to the first column, systemic mycosis, drugs used systemically. Very important broad spectrum antifungal agent is amphotericin B. Amphotericin B is a toxic agent. Amphotericin B is an expensive agent. So it would be worthwhile if we could use one more agent with amphotericin B, and that agent could be flucytosine. Flucytosine would help the action of amphotericin B and can decrease the dose requirement of amphotericin B so that the toxicity will be little bit minimized and the cost of the treatment also can be controlled. Or else we can think of using a better combination, that's amphotericin B. Along with it, we could think of using AZOLES, the azole antifungals. Azole antifungals are Fluconazole, Itraconazole, and voriconazole. So, for systemic mycosis, drugs used systemically, the mainstay of treatment is amphotericin B plus flucytosine, or you can add azoles. The next group which is shown here on this table is called echinocandins or fungins, and these are the newer antifungal agents. This is caspofungin, micafungin, and anidula fungin. So that's about the systemic mycosis. Let's move on to the other side, that's superficial mycosis. For superficial mycosis, you might have to use the drugs by systemic routes of administration. Here we have griseofulvine, then we have terbinafine, and again here there are azoles. That's fluconazole, itraconazole, or voriconazole. So griseofulvine, terbinafine, and azoles. And if the superficial fungal infection could be just managed by local routes, by topical routes, then the most commonly used agent is nystatin. The second one is terbinafine, which could be used by a systemic route. Look at this, it's appearing on this side also, as well as the local route. And again we have azoles, but here are different compounds which are used by local route of administration, and they are miconazole and clotrimazole. Please don't confuse this drug for another sound alike name, and that's cotrimoxazole. You feel I should write it? The antifungal drug which we were saying about is clotrimazole. Another sound alike and spell alike name is cotrimoxazole. There's quite a similarity between the sound and between the spelling. So please don't confuse. Cotrimoxazole is a combination of trimethoprim and sulfamethoxazole. That's cotrimoxazole. And this one is clotrimazole. It's an antifungal agent which is used locally for superficial infections. Let me take you to the next slide. The same thing is written, which was written in the form of a table, and it's just for your revision, just to go through all the drugs and confirm what we heard. Drugs used for systemic infections, used systemically. Pauline antibiotics, now I'm telling you the name of the group, is amphotericin B. A drug which produces anti-metabolite effect is flucytosine, is also abbreviated 5FC. The next group is AZOLES, and there is ketoconazole, Fluconazole, Itraconazole, voriconazole, and a newer agent, posaconazole. And the last group, as I said, are the newer agents, that's echinocandins or fungins, that's caspofungin, micafungin, and anidulafungin. Take you to the next slide. For superficial infections, we can use the drugs systemically or we can use them locally. Drugs used systemically for superficial infections, griseofulvine, terbinafine, and again azoles. And the drugs used by topical routes of administration for superficial infections, number one is Paulines, that's nystatin and harmycin. Let me remind you, another Pauline agent was amphotericin B, but that's used for systemic mycosis. And nystatin and harmycin are other Paulines which are used by topical route of administration. So Paulines, nystatin and harmycin, azoles, miconazole and clotrimazole. You can use terbinafine, which is here also. It can be used systemically, that's the oral route of administration, plus it can be used topically. And lastly, you have some non-azoles. They are haloprogen, tolnaftate, and undecyclinic acid. So this is the plan for the superficial mycosis and for systemic mycosis. Now we try to classify the drugs from another point of view. We try to classify all the antifungal agents on the basis of the mechanism of action. Let's have a look at this. Number one, there are many of these drugs which act on the fungal cell membrane. So drugs acting on the cell membrane. There is a substance called squalene. This gets converted into lanosterol, and the enzyme acting for this conversion is squalene epoxidase. And the drug terbinafine inhibits squalene epoxidase so that it prevents the conversion of squalene into lanosterol. What's the importance of this? This lanosterol is further going to get converted into ergosterol, and ergosterol is going to be useful for the synthesis of the cell membrane. So what is this drug doing is stopping the formation of lanosterol from squalene, and finally the ergosterol synthesis is going to be affected. The second drug, have a look at this. That's the second step I was speaking about, lanosterol getting converted into ergosterol. The enzyme acting on this step is 14-alpha demethylase, and the azole antifungal drugs, they inhibit this enzyme 14-alpha demethylase so that lanosterol is not converted to ergosterol, and finally this ergosterol is required for cell membrane synthesis, so the cell membrane synthesis is going to get affected. The third group of agents are acting in another novel way. What are they doing is they are binding to ergosterol which is required for cell membrane synthesis. The drugs bind to ergosterol and form artificial pores in the cell membrane so that there is leakage of the contents from the cell membrane, and this cell cannot exist, so it will be a fungicidal action or a cidal effect. So binding to ergosterol and forming the artificial pores. Who does this? This is done by Pauline antifungal agents, and they are amphotericin B, nystatin, and harmycin. Next, we have the newer agents, echinocandins. Example is caspofungin. This drug is also acting on the cell membrane synthesis. How? It's going to affect an essential substance required for cell membrane synthesis, And the name of the substance, have a look at the slide, is written here on the slide. The name of the substance is beta-1,3-glucan. So on this slide, you have all the 4 groups of antifungal agents which are inhibiting the synthesis of the cell membrane. I take you to the next slide. Here are the drugs which inhibit the nucleic acid synthesis. So until now we were superficially present, that's the cell membrane synthesis. Now we are going inside the fungal cell, and the drug is going to affect the nucleic acid synthesis. Look at this, there is a drug called flucytosine, that's 5-FC, gets converted into 5-FU, that's 5-fluorouracil. This conversion is done by the enzyme cytosine deaminase. So 5-FC is not active. It becomes active with the help of the enzyme cytosine deaminase and gets converted into 5-FU. 5-FU is 5-fluorouracil, and this is nothing but an anti-cancer agent. So it's as good as we are trying to use an anti-cancer agent as an antifungal agent because it affects the nucleic acid synthesis. Let's come to 5-FU. What does this do? 5-FU inhibits thymidylate synthetase, and when this enzyme is inhibited, there will be affection of the formation of the nucleic acids and the DNA synthesis will be prevented. The next group of antifungal agents, the next mechanism of action, is disrupting the microtubule function. The drugs which disrupt the microtubule function, example, we have griseofulvine, drug which disrupts the microtubule function, the microtubule assembly. So that was the classification of antifungal drugs based on the mechanism of action. Now with this introduction, we start the discussion for systemic antifungal agents used systemically for systemic mycosis. The first drug, as I said, the mainstay of treatment in serious systemic fungal infections is amphotericin B. Amphotericin B is an amphoteric substance and it's got wide spectrum. It's the widest spectrum antifungal agent. Once again, to revise the mechanism of action, is going to bind to ergosterol in the cell membrane and lead to formation of artificial pores, and there is potassium efflux and there is leakage from the cell membrane and the cell is going to be killed. So it will be fungicidal effect. Amphotericin B is usually given by intravenous infusions, and nowadays we have new oral preparations of amphotericin B available, but these are extremely expensive. As it is, amphotericin B is an expensive substance for intravenous infusion, and the oral preparations are still more expensive. As far as amphotericin B is concerned, it's always categorized in the drugs having low therapeutic index. You have heard a lot of pharmacology, and I hope you understand what I'm saying. Low therapeutic index. It means this drug has less safety and it's a toxic agent. Once we remember this fact, we start thinking about what are the adverse effects of amphotericin B. I said the most common route of administration is intravenous infusion, and the first group of adverse effects are related to the infusion. So it's called infusion related toxicity. What is this? The patient gets hypotension, that's fall in the blood pressure, there's fever and chills, there's muscle spasm and vomiting. And this infusion related reaction sometimes could be very severe. To avoid the severity, to decrease the severity of the infusion related reaction, we try to give a slow intravenous infusion of amphotericin B, and in addition, we try to pre-medicate the patient. Before the amphotericin B infusion, we can use analgesic antibiotic agents. We can use meperidine, that's pethidine. Next, we can think of using antihistamines, and the next choice is corticosteroids. So you could use these drugs for pre-medication, and this could minimize the severity of the infusion-related reaction. If amphotericin B is continued for a long time, which is often continued for a long time for serious fungal infections, then we get the dose related adverse effects of amphotericin B. And the most important characteristic is its accumulation in the kidneys, leading to renal damage. This leads to decrease in the glomerular filtration rate. There is tubular acidosis. There's loss of potassium, that's hypokalemia, and there's also loss of magnesium. The use of amphotericin B for a long time leads to accumulation in kidneys, and this leads to decreased erythropoietin synthesis, so that this patient can get various types of blood dyscrasias, most importantly anemia. The last adverse effect of amphotericin B, sometimes noted, is the precipitation of seizures. Patients who are epileptics, this is going to be worsening the condition of epilepsy, because amphotericin B decreases the seizure threshold. Amphotericin B is available as new oral liposomal formulations, and they are called spheres, discs, or ribbons. What is the use of the new oral liposomal formulation? If the patient is not tolerating the intravenous infusion, or sometimes not responding to amphotericin B, can think of using the oral liposomal formulations, because it's not just that a drug is available by oral route of administration. In addition to it, the oral liposomal formulations have been shown to have selective binding to the fungal cell membrane. If we are giving it by intravenous route, it's intravenous infusion, and the drug is going through the systemic circulation. Here is going by oral route of administration, but the liposomal formulation is targeted against certain cells, and this can lead to selective binding to the fungal cell membrane. So this is going to be an advantage, and then a patient who was not responding to intravenous infusion might start giving adequate response to the oral liposomal formulations. Next important thing is, when you give it by oral route of administration as a liposomal formulation, there is less tendency to accumulate in the kidneys. Because this drug is targeted against the fungal cell membrane, there is wide tissue distribution, and comparatively less amount of drug is available to reach the kidneys, and therefore oral liposomal formulations are less nephrotoxic. They also produce comparatively less hypokalemia. But the important issue is the oral liposomal formulations are extremely expensive beyond imagination. Next, we go to the uses of amphotericin B. In which situations we want to use this drug? We said it's a broader spectrum antifungal agent. So it's used for systemic mycosis. The fungal infection which is systemic, which is spread everywhere, we can think of using amphotericin B. It will be the mainstay of treatment. And with amphotericin B, we need to add one or two agents. One could be flucytosine, and as we said, the better option could be AZOLES, azole antifungals. So we start with amphotericin B, we wait for the response, and then we add AZOLES. So what I am saying is, amphotericin B is used for initial induction of treatment, initial beginning of treatment, before starting the azole antifungals. The organisms for which it is used is Aspergillus, so aspergillosis, candidiasis, cryptococcal meningitis, which is supposed to be a very severe fungal infection, and this infection is more likely to happen when the patient suffers with HIV disease, and this comes as an opportunistic organism. Then you can use amphotericin B for histoplasmosis also. As we said about combination with azoles, you can combine amphotericin B with flucytosine for candidemia and for cryptococcal meningitis. So it's specifically the central nervous system for which we think of flucytosine. What's the reason? Flucytosine has got very better penetration in the central nervous system. So if you are using a drug which is able to cross the blood-brain barrier, has a good penetration and is an antifungal agent, it works synergistically with amphotericin B. It helps the action of amphotericin B, and due to this you could think of decreasing the dose of amphotericin B. So flucytosine decreases the dose requirement of amphotericin B, and it's a synergistic effect, or it's a synergistic combination. So the patient is going to receive comparatively less amphotericin B, the cost of the treatment is going to be saved, plus the adverse effects of amphotericin B will be minimized. Flucytosine, good penetration in the CNS. You need to remember this fact. Next, we go to the azole antifungals. As we discussed initially, squalene is converted into lanosterol, and lanosterol gets converted to ergosterol. So lanosterol to ergosterol is the second step, and the enzyme working here is 14-alpha demethylase, and azole antifungals inhibit the 14-alpha demethylase. So conversion of lanosterol to ergosterol will be prevented, and this is going to lead to the affection of the cell membrane. There are drugs under azole antifungals. The first one is ketoconazole, is an older antifungal agent used orally, and it had a narrow spectrum of activity. And this is an alternative to be used for deep or superficial mycosis. Is not the first drug to be used because we got better azoles available. There were certain drawbacks with ketoconazole which brought down the use of ketoconazole. Number one, it inhibits the CYP3A4 enzyme system, and because it produces enzyme inhibition, it could produce precipitate cardiac arrhythmias by terfenadine acetaminophen. If you heard some other sessions, you might have heard the word TAC, terfenadine acetaminophen. It can inhibit the metabolism of midazolam, triazolam, and the HMG-CoA reductase inhibitors or statins used in hyperlipidemia. Secondly, azole antifungals decrease the androgen synthesis, and they can lead to sexual dysfunction. This is very remarkable with ketoconazole. Absorption of ketoconazole is decreased by the presence of antacids. Ketoconazole is available in various forms. There's the cream for local application. It's available for systemic administration as tablets, and there's also a ketoconazole shampoo available. So that's about ketoconazole. Next, we move on to the newer antifungal agents. The first one is fluconazole, can be used by oral as well as intravenous route of administration, and we now say it in reverse way. Fluconazole is combined with amphotericin B, or it can be given after induction of treatment with amphotericin B, and it becomes a drug of choice for cryptococcal meningitis because it's got good penetration across the CSF. It's useful for esophageal and oropharyngeal candidiasis. It's useful for coccidiodiomycosis of the lungs. It's useful in single dose for treatment of vaginal candidiasis. And there is another form of candidiasis which could be severe when the patient suffers from neutropenia. Patient may be an immune compromised host, or the patient has bone marrow suppression and there is neutropenia. Candidiasis is one of the common infections. So you can use fluconazole by intravenous route of administration for 7 days to treat the candidiasis in a neutropenic patient, and then you can put the patient on oral fluconazole. Amongst the newer azole antifungals, we have itraconazole, that's useful by oral and intravenous route of administration. Itraconazole is the drug of choice for blastomycosis and sporothrix. It's also used for aspergillosis, coccidiodiomycosis, cryptococcal meningitis, histoplasmosis, esophageal candidiasis, and dermatophytosis. There are more newer azole antifungals. They include voriconazole and posaconazole. They are newer and they have wider spectrum, and they are used by oral as well as the intravenous route of administration. We need to know the adverse effects of azole antifungals. We already mentioned decreased steroid synthesis, including cortisol and testosterone by ketoconazole. This can produce sexual dysfunction in the form of libido, gynecomastia, and menstrual irregularities, a rare hepatotoxicity, and increase in the liver function enzymes, that's liver function test, is noted, and azole antifungals can lead to gastrointestinal adverse effect. Most notably, all the azoles are contraindicated in pregnancy and they are not safe to the fetus. Then there is hepatic microsomal enzyme system inhibition leading to various drug interactions. So this is the discussion about azole antifungals. On this session, we discussed the classification of antifungal drugs, the mechanisms of action, and we discussed amphotericin B in details, and we discussed azoles. You might have to go to another session to hear about the rest of the antifungal agents. I hope you liked this session. Thank you.